All right, guys, welcome back. Shoulder differential diagnosis. Today we're going to be going over, let's click through here, neurovascular and bony pathology. So the most common ones that I can think of, and the ones I see in the clinic the most often. So on objectives here, we're going to understand the following differential diagnoses. Thoracic outlet syndrome and suprascapular nerve entrapment or palsy, or the neurovascular ones we'll be talking about. And then the bony injuries, we'll talk about the clavicle fractures and proximal humerus fractures. So with neurovascular pathologies, I think it's really important to get really intimate with the anatomy, neurovascular anatomy of the shoulder. And so here are two pictures that I really like. It shows the complexity, also shows you how much is packed in such a tiny space in our bodies. So very, very complex anatomy, but we try to keep it simple. So you can pause those and look at those, but really just notice how these neurovascular structures branch off into various areas, and how something up the chain might affect something down the chain if there was impingement or something of that nature. Here's another picture, and we'll get into what this is in the next slide or two. So, thoracic outlet syndrome, otherwise known as TOS. So it is characterized by compression of the subclavian artery and or brachial plexus as these structures course from the cervical region to the upper extremity. There are three types of thoracic outlet syndrome. One, and the most common, is neurogenic. This is a nerve generated, hence the name, cases. So it comprises 90 to 95% of cases, typically causes symptoms of numbness, pain, paresthesias, paresis in severe cases, and this is obviously nerve-like symptoms. And you also have arterial and vascular thoracic outlet syndrome, and we'll talk about those more as we go along. So sticking with neurogenic, this is usually due to compression of the brachial plexus at some point in the chain. So it could be compression at the scalene triangle, the cervical rib or the first rib, the pec minor, the costoclavicular space, or if you have an unstable anterior humeral head, you can have compression into the brachial plexus that way as well. This can cause symptoms down the arm. So diagnosis of thoracic outlet syndrome is made by clinical exam, and it's really a lot of diagnosis of exclusion. So we think of other things are more common, like cervical radiculopathy, things like that, maybe more common, that give you the similar sort of symptoms down the arm. If you notice that this is a vascular case, meaning an arterial or a venous case, that would be immediate medical attention is needed. Refer them out. Demographics here, young and middle-aged adults are most commonly affected. Females are more likely 3-to-1 ratio than males. And teenagers who get diagnosed with a cervical rib might be experiencing thoracic outlet because it's one extra bony piece of anatomy in a tightened space. This is just a variation of normal. It's just your C7 has a rib attached to it, much like a first rib. And of course, incidence with participation in overhead sports is common. So signs and symptoms. You're going to get your nerve symptoms like intermittent numbness and tingling, most often in the medial forearm and hand, kind of like C8, T1 nerve root distribution. You're going to have pain in the neck, arms, shoulders, upper back. Could be aggravated by overhead activities, repetitive activities. But I want you to notice here is the top picture. This can be your venous type of thoracic outlet syndrome. You see the cyanotic swollen arm. It's probably a baseball player just by the build of this individual. And you can find more information here. And then, of course, this would be your arterial type. As the bottom picture, you can see the blanching of the hand, cool extremity, absent arterial pulse, muscle cramping, paresthesias, etc. Both these are need for medical attention. Looks like the top person's been in the hospital, which is good. So those are things you should look out for. Causes: poor posture. This is a rabbit hole we don't need to go down into yet. But if you're in a posture, let's just leave it at that. Poor posture for now. We will get into my opinions of posture later on. But I think posture is a very variable thing, and you can't pinpoint thoracic outlet syndrome or any diagnosis, I think, to poor posture in isolation. So presence of a cervical rib, we talk about that. Could be occupational, a traumatic injury like a whiplash, overhead throwing sports, even carrying a backpack or a heavy sack, on your shoulder for long periods of time. And we look at differential diagnoses. Big one here is cervical radiculopathy. You want to rule that out. And obviously there'd be contribution from the neck with that one. Whereas in thoracic outlet syndrome, you wouldn't get true neck symptoms. And I say that with a grain of salt, but stick with me. You'll learn cervical radiculopathy test cluster that'll help you rule in or rule out that. Any of the peripheral nerve pathologies of the upper extremity, you want to rule in or rule out. And then the big one here at the bottom is this red flag, this tumor. It's an apical pancreas tumor. Look that one up, okay? So tests and measures. Really, these tests and measures are to determine if there's a vascular cause, like the Addison test or the costoclavicular test or the Ruse test. These are all common tests and measures to look for vascular issues of the arm. Your nerves, you'll just do the upper limb tension test. You also just get a sense of palpation into those three areas, your scalenes, pec minor, or the supraclavicular space. You'll see if those reproduce symptoms. You'll also do a neurological exam. You want to look for reduced sensation or absent or reduced deep tendon reflexes, weakness in grip strength, etc., etc. So that's how you would try to diagnose in the clinic. You may want to refer for imaging if you feel and palpate what you think might be a cervical rib. I've never felt one. I've never seen an image of one with one of my patients, but it's known in the literature to happen. So there you have it. So interventions, what we do? Well, the first thing is that you have to stop the aggravating activity for a period of time. And then simply gradual and graded exposure back into that activity. So activity modification is probably the number one thing. You can see the other things that I would do here. Various types of modalities if needed. Periscapular, muscle activation, rotator cuff strengthening, core and postural exercises, patient education, nerve glides. I rarely do things like first rib mobilizations or soft tissue work into those areas because I think adding compression to the anatomy that's already dealing with a compressive type of pathology is not something I want to do. In chronic cases of neurogenic TOS, they may need surgery to relieve those impingement areas. They do things like a first rib removal or a scalenectomy or a pec minor release to relieve pressure on the nerves. And then if you notice venous or arterial thoracic outlet, this would be immediate referral and very likely surgery in my book. All right, let's talk about suprascapular nerve entrapment next. So this is the most common type of nerve entrapment is of the suprascapular nerve. It involves a C5, C6 nerve roots, but this is a peripheral nerve issue. Provides motor innervation to the supraspinatus and the infraspinatus. The nerve is commonly compressed in athletes who excessively abduct the arm in a full rotation, meaning overhead athletes, throwers, swimmers, etc. It's important to understand the anatomy. So entrapment of the suprascapular nerve may occur either at one of two places, the suprascapular notch or the sphenoglenoid notch. And those two areas are listed here. You have this transverse ligament that goes across the suprascapular notch. The nerve can get impinged in this area, and then you'll have atrophy or muscle wasting or weakness of both the supraspinatus and the infraspinatus because it's everything below the chain here. Meanwhile, if you have just impingement of the nerve at the sphenoglenoid notch, the supraspinatus would be salvaged, but the infraspinatus would have the issue. So that's when we could try to differentially diagnose where the injuries occurred. So patients will present with vague shoulder pain, usually posteriorly. Abduction is usually limited in the first 30 degrees in terms of strength. EMG studies, nerve conduction velocity studies, have been shown to have a 91% positive predictive value. MRI may show atrophy of infraspinatus or supraspinatus. The demographics here is usually it's reported in throwing sports, volleyball, tennis, weightlifting, and swimming. Other possible contributing causes, compression of the nerve can also result from a ganglion or cyst. This is also known as a paralabral cyst. It's usually from a posterior labral tear. So we'll get into that here. Picture on the left is just another picture of the anatomy of the suprascapular nerve and where it transverses. And the picture on the right is a posterior capsular / labral tear that's created this cyst. And it's compressing at the sphenoglenoid notch, the suprascapular nerve, so the infraspinatus would be affected. Atrophy. In the picture on the right, you want to have your patient stand with their shirt off, especially if the vague progressive onset of weakness with no true mechanism of injury. You want to get a look at their muscles, and you can see obviously the muscle wasting in the infraspinatus here. It's hard to tell about supraspinatus, but certainly infraspinatus. They're limited range of motion. They have weak external rotation and abduction. Those are the big things with signs and symptoms and functional limitations. In terms of differential diagnosis, you want to try to see if what they're dealing with is maybe a labral tear posteriorly or slap tear, cervical radiculopathy, or other nerve pathologies. And again, you can see the muscle wasting here in the infraspinatus. So tests and measures, really it's going to be an EMG and MRI, but your in-clinic observation of function and muscle contours, checking for atrophy, is going to be your biggest test and measure in clinic. And so one thing I want you to understand is not just repetitive overuse that might cause this or a labral tear. It can be direct compression. And so I had one case of this where the guy was a power lifter and he switched to low bar squatting and started developing weakness on his bench press. And really what happened was he lost shoulder stability because his rotator cuff, infraspinatus, was atrophying and not firing as strongly, and so he felt unstable on his shoulder. And it's truly because of the the back squat position. So we changed him to a high bar back squat, and about 3 months later, he returned to full competition. So just understand you can relieve symptoms by getting rid of compression. So again, what I just said is the first bullet point here. So removing or stopping irritating positions or that sort of thing, backpack, decrease volume of throwing or swimming, low bar squat, get to a high bar. Chronic cases may require arthroscopic or open release of the suprascapular nerve. This would be to relieve tension on the nerve, obviously. If you have a paralabral cyst, what they'll do is they'll go and they'll repair the posterior labrum and capsule and then remove the cyst. So postoperatively progress as tolerated with scapular and cuff programming. Unless you have a concomitant procedure like a posterior labral repair, you'll follow that protocol instead. Right, now we'll get into common bony pathologies, looking at clavicle fractures and proximal humerus fractures. And as we move along here, we'll start with the clavicle. So, chances are someone in the class has fractured their clavicle. Just if they've been in contact sports, probably someone in class, I would bet, has. So usually it involves a fall onto the tip of the shoulder or blow to the shoulder area, pain and point tender along the shaft of the clavicle, and you might notice skin tenting. We'll have a picture of that later. This is one of the most frequent fractures in sports. It's usually from falling on the tip of the shoulder or outstretched arm or direct impact, as I mentioned previously. Most often occurred in the middle 1/3 of the clavicle. And the demographics here is athletes participating in contact sports, maybe elderly individuals who suffer a fall, cyclists or triathletes who are moving at high speeds. You can lump skiers into this category, We have a lot of these up in Minnesota here. So this is what it looks like on the x-ray, top left. Pretty obvious anatomical variation there, injury. And so what that looks like on the bottom left in real life is a closed fracture, which produces this skin tenting. And if you obviously you can see on his right side the clavicle fracture versus the left, there's nothing. And so they'd go in and they fix this using plate and screws. And this is what that looks like. So this is a left-sided clavicle fracture fixed with open reduction internal fixation of the fracture. So think about what that means. Open reduction internal fixation. I want you to think about what that means. ORIF. Okay. So what do we do for interventions? Well, if you fracture your clavicle, this needs to be seen by a physician. Radiographs need to be taken to interpret the extent of the injury. Maybe surgical intervention is warranted. Some cases are non-operative. If they are non-operative, we go 4 to 8 weeks, depending on bone health of the individual, of immobilization. We get radiographic evidence that the bone is healed, and then we begin a slow and progressive range of motion loading program. In the post-operative setting, we go 4 weeks, little to no range of motion, just letting the bone heal. And then from weeks 4 to 6, starting some range of motion, 6 to 12, progressing to active to light weightlifting, and then after 12 weeks, full clearance back to weightlifting if we see radiographic evidence the bone is healed. All right, proximal humeral fractures. So any defect in the continuity of the proximal humerus following a fall, we'd be suspicious of a proximal humerus fracture. And this can be a closed or open fracture, meaning it's retained within the confines of the skin, or sometimes they're bad enough, like in a car accident, where you'll get an open fracture, meaning the bone will pierce through the skin, creating an open environment. This usually occurs primarily in older patients who take a fall, which is why balance and fall prevention is so important. Just think this picture on the right always struck me as just a little odd, just the shape of the head. And anyways, you won't forget this picture. Let's put it that way. It's a Fuchs injury, obviously, and then the tip of the shoulder landed on the ground. So signs and symptoms: pain, point tenderness, swelling, bruising, loss of general function, muscle guarding. You can tell something's wrong after a fall, right? So you're basically going to present in a position of shoulder adduction, internal rotation, elbow flexion, that guarded position. And the patient won't be able to tolerate any real functional use of the arm. Just unstable. So possible contributing causes, well, may have osteoporosis or poor bone health. We always want to know about the mechanism of injury, where it's a high energy trauma or a violent muscle contraction, like if you have a seizure, or is it direct blow to the humerus like an athletic event, or is it falling on an outstretched hand? Does the person have impaired balance? Or are they on a lot of medications that might affect their bone health? So differential diagnosis includes shoulder dislocation, scapular fracture, AC sprain, rotator cuff strain or tear. And then finally here, interventions. So only proximal humerus fractures that disrupt the integrity of the articular surface, meaning the joint space is widely, or bone that's widely displaced, require surgery. So if it's not affecting the joint and it's not a very displaced fracture, they might just put you in a sling. Otherwise, you might need surgery. So if we look at the very bottom, you can see that much like the clavicle fracture, you have an ORIF in picture A. So plates and screws to help fix the fracture. In picture B, you have what we call an anatomical total shoulder arthroplasty. We'd know this as a total shoulder replacement in vernacular. You can see that this tries to mimic your normal shoulder anatomy, creating a ball on the humeral side and then a socket on the glenoid side. And it actually looks like they don't have a glenoid sided articulation, most do. And then in C, we have a reverse shoulder arthroplasty. And you can see how the articulation of the ball and socket has flipped, where the excuse me, the socket is on the humeral side and the ball is on the glenoid side. And in the postoperative lecture, you will learn more about this. So again, I just want to thank you guys. This was the shortest lecture. I'm sure you guys are happy about that. And send me questions, just like we mentioned in class. Linville B, my first name is actually Brian. And so they have to use my first name, Linville B at franklinpierce.edu. But thank you guys for tuning in. And again, open book for you guys if you need it. So appreciate it. Thank you.